So now I'm going to talk about drugs that affect contractions and lactation. So the main topics for this lecture is drugs that stimulate contractions and lactation, and drugs that inhibit contractions. The drugs I will talk about that stimulate contractions are oxytocin, vasopressin, and prostaglandins. And drugs that inhibit contractions that I will talk about in this lecture are nifepridine and atosiban. So the main point to remember from this lecture are drugs that stimulate contractions, oxytocin and prostaglandins, and drugs that inhibit contractions, such as nifepridine and atosiban. Oxytocin is a very interesting molecule. It is involved in falling in love, and also it is excreted during orgasms. So it is also called the love hormone. And it is also used to induce contractions in childbirth. Oxytocin is a pituitary hormone, and pitocin is a synthetic oxytocin, which is also used during childbirth. Oxytocin stimulates smooth muscles in uterus for contractions. Indications is initiation of childbirth, stimulation of secondary impairment of contractions, and atonic hemorrhage postpartum. Oxytocin can also be used as a nasal spray. It influences expulsion reflex to facilitate lactation and pumping. And it is also used as a prophylactic of masticite. And it can also give relief from established masticite. This figure shows different parts of the body where oxytocin acts. It acts in the central nervous system, in the testis, when it comes to ejaculation. And it is also active in the uterus, giving contractions. And it is also active in the mammary gland, causing milk ejection. Oxytocin has a number of effects on the body. It has an anorexigenic effect, anti-nociception, an anxiolytic effect. It is involved in maternal behavior, very important for maternal behavior. And it is also very important for pair bonding. And it may give a salt appetite, and it is involved in sexual behavior and in social recognition. It is a very important molecule for animals and also human beings. Oxytocin binds to the oxytocin receptor. Oxytocin receptor levels increase in the myometrium and the endometrium of the uterus at the end of the pregnancy. And the oxytocin and its receptor system plays an important role in childbirth and breastfeeding. Oxytocin affects several types of behavior in the central nervous system. It is involved in stress and anxiety, and it has been shown to have an antidepressant effect in animal studies. It is involved in sexual behavior and in bonding, the process of being emotionally linked to one another. And it is also involved in motherly behavior, or in other words, maternal behavior. And in some mammals, the oxytocin receptor is also found in the heart and the kidneys. So a little bit about dosage and administration at birth. It is given intravenously or intramuscularly. And it cannot be given orally because it breaks down in the gastrointestinal tract. It is given intravenously as a slow infusion to induce labor. And it has a very short half-life. The half-life is 3 to 5 minutes. There are several cautions with oxytocin. It should not be given. It should only be given in the maternity ward under continuous medical supervision. And it must be used with utmost care when suspected placenta insufficiency and in threatening fetal hypoxia, and also conditions that can predispose to uterine rupture. For instance, if there has been a cesarean section. Oxytocin is a very powerful drug. It has very heavy actions. And overdosage may result in uterine rupture. There are some contraindications that are very important to be aware of. If there is a mechanical mismatch or mechanical barrier to vaginal birth, if there is a fetal distress syndrome, or if there are hypertone uterine contractions. There's no risk of use during pregnancy. The uterus is affected by oxytocin just in the last period of pregnancy, when the body starts to get ready to give birth. And this is a figure to show how oxytocin is involved in milk production. You can see the baby is suckling on the breast, which gives the response in hypothalamus, which affects the posterior pituitary and the anterior pituitary, where oxytocin is released in the blood and is involved in milk letdown. So, Moving on to vasopressin. It is also called antidiuretic hormone, ADH. And it has two main functions: to tie water and to contract blood vessels. The molecular structure is very similar to oxytocin. So cross reactions may occur. Oxytocin may seem a little antidiuretic, and vasopressin may cause uterine contractions. So we're moving on to prostaglandins. The name prostaglandin is derived from the word prostate. And prostaglandins were first isolated from semen in 1935. These are strong signal molecules that regulate smooth muscle contractions and relaxation. Misoprostol is a synthetic prostaglandin E1 analog. It causes uterine contractions and cervix maturation. It is used for induction of birth. And it is also used for prevention and treatment of postpartum hemorrhage. It can also be used for drug abortion and treatment after incomplete spontaneous abortions. Misoprostol can be given both vaginally and orally. If the Bishop's score is higher than 5 to 6, you may induce birth by amniotomy or infusion of oxytocin. But if the cervix is immature, birth can be induced by misoprostol orally or vaginally every 3rd to 6th hours. Misoprostol is as effective as other methods of induction of birth, and oral dosing carries less risk of hyperstimulation than vaginal dosing. Misoprostol is contraindicated in previous cesarean sections due to risk of uterine rupture. Misoprostol is abortion-inducing, and there are indications that prostaglandins, especially misoprostol, may cause malformation in unsuccessful attempts of abortion, probably due to vascular effects. So if a woman has an incomplete abortion caused by misoprostol, she should have another method of abortion. So moving on to dinoprostol. Dinoprostol is a prostaglandin E2, and it works contracting on uterine muscle throughout pregnancy. It is used in different formulations for cervix softening, for birth induction, first trimester abortion, and induction of abortions in the second trimester. And also it can be used for induction of birth in special cases. For instance, if the fetus is dead, or if there is an encephalopathy. Oh, sorry. Route of administration is intracervical or vaginal. You give 0.5 milligrams per hour, possibly increasing to 1 milligram every hour, applied intracervically. Dinoprostone should be used only in hospital wards with expert supervision. Should be also be careful if there is an abnormal uterine activity, for instance, increased frequency or attention or duration. The fetus may show turmoil and altered heartbeat, and it's important to observe the fetus. There are some potentially serious side effects. Dinoprostone may provoke asthma-like seizures, cardiovascular events such as heart attack, severe uterine contractions that may lead to cervical rupture. It can occur. And it may also cause fetal death. When it comes to dinoprostone, it should not be used where oxytocin is generally contraindicated. And it is important with continuous monitoring of uterine activity and the heart beat of the child. Dinoprostone may be teratogenic. It means that it can harm the fetus. And if pregnancy does not end with dinoprostone, it should be terminated in another way. This is a medication that is not in Felleskatalogen. It is a preparation for approval exemption. It's preparat på godkänningsfritak. So now we are moving on to medications that can be used if there is a threatening premature birth. Medications that may stop uterine contractions. Nifedipine is a calcium antagonist. And its mechanism of action is that it inhibits calcium influx into small muscle, which leads to its inhibition of calcium-dependent myocyte contraction and vasoconstriction. It is used as a first-line drug to inhibit contractions, possibly before the administration of tractosile, which I will come back to later. It is not indicated in Felleskatalogen, so it is also medication on godkjenningsfritak. The safety of use during pregnancy has not been established as the human experience is insufficient. But there have been animal studies, and teratogenic findings have been seen in rats, mice, and rabbits. But the embryotoxic, placentatoxic, and fetotoxic effects have been seen at doses that were toxic to mothers and several times higher than the recommended human maximum dose. So, in other words, the dosages in animal studies are higher than what is used in humans. Then I'll talk about atosiban. Atosiban is a synthetic peptide with oxytocin antagonistic effects. And the molecule is quite similar to oxytocin. So it's very interesting on a molecular level. Atosiban reduces the frequency of contractions and the tone of the uterus, thereby inhibiting uterine contractions. It is used for postponement of threatening preterm birth in pregnant women in the following cases. When there are regular uterine contractions with a duration of at least 30 seconds and a frequency of more than 4 contractions per 30 minutes. Also, if the cervix is affected, and if it is used if the gestational age is from 24 to 33 full weeks. And there must be no signs of intrauterine asphyxia. And no evidence of intrauterine infections. Atosiban is intravenously administered in 3 consecutive steps. First, you give an initial bolus dose. This is immediately followed by a continuous high-dose infusion for 3 hours. This is followed by a lower dose for up to 45 hours. And the duration of treatment should not exceed 48 hours. An intravenous treatment with initial bolus injection of atosiban should be started as soon as possible after the diagnosis of threatening preterm birth has been established. It is important to control the fetal heart reaction and the contraction activity. And if there are signs of intrauterine infection, this will indicate termination of treatment. It should not be given before 24 weeks or after 33 completed gestational weeks. It should not be used in conditions in which mother and fetus continuation of pregnancy is risky. And the benefits of the delaying delivery should be considered against the potential risk of chorioamnionitis in cases where premature membrane rupture cannot be ruled out. There are no evidence of adverse effects on the fetus, but it may possibly inhibit the milk expulsion reflux since it is an oxytocin antagonist. And there are no specific side effects that have been shown in the newborn. I'd like to end this lecture with giving you some homework. I want you to do something that increases your oxytocin levels, so you get the feeling of this molecule. And if there are any questions, feel free to email me.